Hi, I'm Myra Butler, a recent graduate from medicine and currently completing my Master's of Health Science in Clinical Epidemiology at the University of British Columbia. In this video, we will go through the basics of study designs. I hope you take away a basic understanding of the main types of study designs and that you understand the usefulness of comparators, randomization, and blinding. Learning the strengths and weaknesses of each design should enable you to choose the most appropriate study design for your research. There are many different types of studies, from observational studies, like a case-control trial, to an experimental study, like a randomized control trial. As we go through this material, I would invite you to fill out the blank reference table or create your own for future reference. These are the headings I chose to include for my reference table. Feel free to customize the table according to what makes sense to you. Case reports and case series are a description of a single or set of cases with a specific outcome. A case series, the set of cases, has some common factor to them. These simple descriptions are meant to alert the scientific community of new presentations, new side effects or risk factors, possible safety concerns, and perhaps even suggest the beginning of a trend. In order to be published, there must be something new or atypical about the case. Clinicians choose this type of study for something odd that they have noticed in their practice. A larger series has a higher likelihood of having a real association with the outcome. This type of study is particularly good for rare outcomes, side effects, and presentations. In fact, this may be the only way of finding extremely rare events, since other types of studies would have to be simply enormous to find such rare events. The other advantage is that these are fast and inexpensive. The major limitation to a case report or series is the fact that there is no comparator group. This may be part of the spectrum of normal that's never previously been described, or it may represent a serious threat. In order to tell, you must have a measure of risk for a population at risk, neither of which are present in a case series or case report. Furthermore, the temporality of the exposure compared with the outcome can be difficult to determine. There's huge potential for selection bias, since the clinician must think the case is somehow special and then convince peers and a publisher that it merits publication. There's also potential for information bias through things like recall bias, survivor bias, and surrogate bias. A comparator group allows for comparison between normal controls and cases, or between those exposed and unexposed. It moves the study from an individual level to a sampled population level. Having a comparator allows for a relative measure of risk. Furthermore, it decreases significantly the chance of a placebo effect and the Hawthorne effect, i.e., an effect secondary to observation alone. The weakest comparator observational study design is the cross-sectional study. An easy way to remember this study type is to think of it as a population snapshot. Sample a study population and then split that sample into 4 groups: those who were exposed and have the outcome or disease, those who were exposed but are disease-free, those who were not exposed who still have the disease, and those who were not exposed and do not have the disease. Set up your 2x2 table like you learned in the outcome measures video and fill in the boxes. You can calculate and compare the prevalence of your outcome in your full population, exposed, and non-exposed populations. This brings us to the advantages of a cross-sectional study. It's a very good first step type of study that can measure multiple exposures and outcomes. You can measure prevalence of your outcome in the population and is relatively fast and inexpensive, especially if it's a small study. The drawbacks of a cross-sectional study are there may be significant selection bias in the sampling of the study population. Since this measures prevalence and not incidence, there's no true measure of risk. Information about the outcome and exposure were collected at the same time, so temporality is unclear. The exposure may precede or follow the outcome. Although these studies are good for bringing new associations to light, they rarely establish causality. There's a high chance of confounding, as well as bias, including prevalence incidence bias and recall bias. In general, they're thought to be good studies for hypothesis generation. A case control study samples a population and then separates the participants based on their outcome. Once the participants are separated, they are further separated into those who were exposed and those who were not exposed in order to fill up that 2x2 table. In other words, you collect a group of patients with the outcome of interest, also known as cases, and a group of patients without the outcome of interest, also called controls, and compare their exposure histories. There are two ways of assembling these two groups. You can start with a population of interest, like elementary school children in BC. This method allows for easy selection of representative controls, since you have a good understanding of the population under study. The difficulty is making sure that you include every single possible case of the outcome. Another option is to start with a particular set of cases. For example, all people diagnosed with multiple sclerosis at the MS clinic. In this case, getting all the cases is less difficult, but deciding what a reasonable control group is much more challenging. In other words, what is the population from which these cases were drawn, and how can you get a representative sample of that population for comparison? As discussed in the Outcomes Measures video, you can calculate an odds ratio for a case control study in order to have a measure of risk of those exposed compared to not exposed. The advantages of a case control study are that they are very good for rare outcomes and diseases. It's a good second step after a case report or cross-sectional study. Unlike earlier studies, you get a measure of risk. They tend to be fast and relatively inexpensive. You can still explore multiple exposures and even multiple levels of exposure to get a dose-response type relationship, which you can put towards a hypothesis of causality. Unfortunately, case control studies are limited to a single outcome, since participants are chosen based on their outcome status. Furthermore, despite the measure of risk in the odds ratio, there's no measure of incidence or prevalence possible. The necessarily retrospective nature of this study design casts doubt on the temporality. The choice of controls can entirely change the findings of the study, and so must be done very carefully to avoid errors. Even with very careful study design, these studies remain subject to confounding. Case control studies are subject to selection bias, which can be somewhat mitigated by including consecutive cases from a particular source with an explicit, appropriate selection of controls. Recall, survivor, and surrogate biases are also possible due to the retrospective nature of exposure status determination. Unlike case control studies, where the sampled population is separated based on outcome, a cohort study separates participants based on their exposure status. Once their exposure status is determined, they are followed forward to determine whether the outcome occurred or not. Once again, this allows you to fill in that 2x2 table. A cohort study allows you to measure the incidence of the outcome in both the exposed and unexposed groups, which means you can calculate the risk difference, number needed to treat, relative risk, and odds ratios. The definition of a cohort is a group of people with something in common. There are two types of cohort studies. An exposure-based cohort study compares an exposed cohort of people to a non-exposed cohort. For example, comparing the rates of mesothelioma in asbestos miners as compared to coal miners, with the exposure being asbestos mining. Population-based cohort studies, on the other hand, choose participants based on a population of interest, and then split that population based on exposure status. One of the largest such studies is the Framingham Risk Study. A population-based cohort study can also give you the population attributable risk of an exposure. There are advantages and disadvantages to each type of cohort study. An exposure-based cohort allows for a smaller sample size for rare exposures. However, you are limited to a single exposure. A population-based cohort, on the other hand, can look at multiple outcomes and exposures, but must be a massive study in order to pick up differences due to rare exposures. As you can see, although you get to the odds ratio the other way around with a cohort study as compared to a case control, you end up with the same formula in the end. Another thing to consider about cohort studies is their directionality in terms of time. A prospective cohort study is when populations are defined and then followed forward to determine outcome status. In a retrospective cohort study, the population is defined, and then its past exposure and current outcome statuses are determined through chart review or whatever form of data collection available. In both cases, however, the actual data collection happens in the forward direction, making this a stronger study design with respect to determining causality, because the temporality is clear. Prospective cohort studies tend to be rather expensive and long, with difficulty maintaining contact through the final follow-up visit. Even so, they are less subject to bias, and you can collect all important exposure and outcome data in the form you need. Retrospective cohort studies are much less expensive and relatively simple by comparison. However, there is a greater possibility for bias, and you are limited by the data available to you in whatever data source you choose. Since this data may be repurposed, it may be what we call dirty or missing significant chunks. In summary, cohort studies, in particular exposure-based cohort studies, are ideal for rare exposures. If it would be unethical to randomize people to an exposure, a cohort study may be the highest level of evidence you're able to obtain in a human population. The temporal sequence from exposure to outcome is clear. Often you can create a dose-response relationship with different levels of exposure. All these together can suggest a causal relationship. In addition, you can examine multiple outcomes, and in a population-based cohort, you can even study multiple exposures. As compared to case control, cohort studies minimize recall, reporting, and survivor bias. Unfortunately, especially prospective population-based cohort studies require a huge organizational effort to enroll and follow up with every patient for the full follow-up period. If loss to follow-up is significant, the validity of the study results may be questionable. Furthermore, there remains the possibility of confounding, and missing subclinical disease may result in bias. Cohort studies are not suitable for rare outcomes, since the number of people you would have to enroll would make it impossible. The most likely biases for cohort studies depend on the temporality. Prospective cohorts are most likely to suffer from attrition, interview, and selection bias, secondary to non-response or refusal to participate. Retrospective cohorts, on the other hand, may have some of the same biases as case control studies. If researchers are not blinded to the outcome status of patients, there may be a type of recall bias where researchers look harder for exposure in those with disease than in those without. You can also still get survivor and surrogate biases in this type of study as well. Now let's move on to experimental studies, where the researcher controls the exposure status and observes the outcomes. Without randomization and blinding, the biases closely resemble those of a prospective cohort study, namely attrition, interview, and selection biases. The purpose of randomization is to even out known and unknown confounders across study groups, thereby balancing their effect, except with respect to the exposure the researcher is controlling. This is a relatively new technique from the late 1800s, which did not make its way into the world of medicine until the 1950s, where it is now recognized as a superior type of study design. In fact, there's a whole group devoted to improving the quality of randomized controlled trials called the Consort Group. They set out guidelines for how to create randomization patterns and how to allocate patients, etc. In order to preserve the benefit of balancing known and unknown confounders, analysis must be conducted on an intention-to-treat basis. Furthermore, significant loss to follow-up can also break randomization, thereby casting doubts on study validity. Another method used to decrease bias is that of blinding. There are 4 possible levels of blinding. The first is no blinding, also called an open-label study. A single-blind study usually refers to a study where participants are blinded to their exposure status. Double-blind studies, the participants and researchers are blinded, while triple-blind implies those doing the statistical analysis are also blind to exposure status. Although these are the conventional definitions, it is best to specifically explain the method of blinding and how it was maintained throughout the study for clarity's sake. Blinding can be broken, especially if there's a specific side effect with the active compared to the placebo arm. Remember, patients and researchers are smart and they might talk to each other. A simple measure of how well blinding was maintained is to ask both participants and researchers to guess their exposure status at the end of the trial. If they guess incorrectly as much as they do correctly, you can be pretty confident that your method of blinding was effective. Randomized controlled trials require what is called clinical equipoise in order to be considered ethical. This means that there must be real controversy in the literature and/or expert community over which treatment is superior. Your research team can have a strong opinion about which will be better, but the scientific community on the whole must disagree about the best treatment. There are 2 main types of randomized controlled trials: those that deal with efficacy and those that deal with effectiveness. Efficacy trials establish that an intervention works under ideal conditions, usually in a high-risk population. Effectiveness trials, on the other hand, focus on how well interventions will work in the real world. For example, abstinence is the most efficacious form of birth control. If you are abstinent, you will not get pregnant. Unfortunately, abstinence is not the most effective form of contraception, since any lapse in abstinence could result in a pregnancy. As a result, oral contraceptives may be more effective, though less efficacious, form of birth control. It's important to determine what type of randomized controlled trial you're dealing with in order to understand how far you can generalize the results of the study. If the RCT is an efficacy study, the generalizability might be minimal. Effectiveness randomized controlled trials, on the other hand, tend to be more generalizable to a broader population. Since you are controlling the exposure status and measuring the outcome, you can calculate the efficacy, for example, a mean difference in blood pressure, the risk difference, number needed to treat, relative risk, and odds ratio. The greatest advantage of RCTs is that they even out the effect of known and unknown confounders. This is huge and not available for any other type of study design. They have high internal validity and can establish causality since their temporality is clearly forward and a dose-response curve can be plotted. Blinding further decreases the risk of bias, and since it's prospective, you can collect all the information you think is important. These studies tend to be quite involved, so there's usually a pretty good follow-up rate too. If, however, it's unethical to randomize patients to either arm of the study, it's unethical to do the study. Even if it is ethical, it will take significant time and effort to develop the protocol and consent in order to get approval from your local ethics board. Furthermore, these studies are quite involved and require lots of time, energy, and funding. Worse than the logistical nightmare, these trials may have unplanned crossovers and non-compliance which may break randomization. Blinding may be lost, as discussed above. Finally, if the inclusion and exclusion criteria of your study are too strict, the generalizability may be limited. For example, if you limit your study to left-handed men from 20 to 25 years of age, it's unlikely you will be able to generalize your findings to the full population. Although randomized controlled trials are generally a very robust study design, they are still subject to bias. In particular, look for selection bias and Hawthorne bias. A consort diagram can really help you determine the risk of selection bias, since it takes you through the whole sampling to analysis process. You need to think about selection bias in every step, from general population to sampled population to randomized population to the allocated population, etc. If 700 patients are assessed for eligibility and only 7 are eligible, there's most likely a significant selection bias. When analyzing randomized controlled trial data, it's imperative that the intention to treat principle be followed. In other words, no matter what actually happens, the outcome is attributed to the group that person was randomized to. For example, a study comparing medical to surgical treatment of appendicitis, the outcomes of all those randomized to surgery are compared to the outcomes of all those randomized to medical treatment. The actual type of treatment received at a certain level is irrelevant. It is only with intention to treat analysis that randomization is maintained, and therefore the benefit of balancing known and unknown confounders stands. When data are analyzed on an as treated or as delivered or as received basis, randomization is broken and its advantages forfeit. This type of analysis is a special type of subgroup analysis subject to the same disadvantages, confounding, and biases as prospective cohort studies. So, what do you do if you are missing a bunch of outcome data? There are many different methods of intention to treat analysis taking missing data into account. You could assign those lost to follow-up the best or the worst possible outcomes. You could extrapolate the trajectory of their early data to an expected final outcome. You could use the data you have to generate likely outcome data, also called multiple imputations. Whatever type of intention to treat analysis used ought to be specified a priori, in other words, before the study, and justified based on the expected results. Nevertheless, you likely want to know just how much of an effect those lost to follow-up data had. For that, you can do a sensitivity analysis. Sensitivity analysis is a fancy term for try it one way and try it another and then see how different they are. If your intention to treat analysis done multiple different ways essentially agrees, you can be pretty sure of your outcome. If, however, imputing the best and then the worst possible outcomes changes your study results entirely, it's likely your large loss to follow-up has left you with essentially useless data. Next time you're preparing for journal club, here are some places you can turn. For observational studies, check out the Strobe checklists for evaluating studies. The guidelines there can also help you in the design and writing phases. Similarly, for RCTs, check out the Consort group for guidance. I find the checklists are particularly helpful because they guide you through the process of critical appraisal and point out likely sources of bias, error, and confounding. This material is drawn from many UBC School of Population and Public Health classes and the 4th edition of Epidemiology by Gordis. I hope your study designs table is filled out and will serve you well in the future. Thank you for your attention.